I want to address some of the things that we've been talking about here in terms of a lot of payer formularies are based on guidelines. In this case, a GOLD is the most common, right? So how does the GOLD guideline or anyone else affect your formulary in terms of stepwise management, building from 1 to 2 to 3, and do you even approve triple therapy?
So we try to be evidence-based. So of course, the role of national guidelines plays a role to the extent that they outline what categories, what LAMA combinations or ICS combinations based on mild, moderate, severe disease. So obviously that's overarching. When we're in a P&T committee and we're looking at a drug, we're starting with what's the category, what's the mechanism of action. But we're also looking at what's the efficacy in clinical trials, particularly around exacerbations. We've moved beyond FEV1 and really are looking at what's the impact on exacerbations, because in the end, that's also the big impact on total cost of care. We'll certainly also look at safety, including black box. Obviously, if one drug has a black box, another does not, that's an area of differentiation. We do have pulmonologists that are practicing, also part of that committee, to give us exactly the kind of feedback that we're getting here in this discussion. And in the end, generally speaking, in the area of COPD, it's about choice. And one of the things I heard from both the thought leaders here is that there needs to be choice to be able to individualize what that patient needs based on symptoms. So although a drug may not everything's Tier 2, unrestricted. Tier 2 is typically non-preferred. But usually there's options on a preferred tier that satisfy, if you will, the need for some individualized choice across different classes. Some payers are actually covering the triple combination, because I think we all recognize that for some patients, and probably those that are most severe, in order to keep them out of the hospital, out of the ER, better controlled, that convenience and adherence may tie together. And that's what success is going to look like if we're going to manage to total cost of care. Others may put some more restrictions or perhaps move the triplet to a non-preferred tier, which has cost share implications for patients. But I think you're seeing some also recognize that there's value in choice and maybe also an opportunity for contracting. But that said, I think we recognize the importance of COPD and doing a better job in choice and access to remove barriers to patient adherence.
And let me just throw out one thing, which is one of the things we found across a number of my different roles, whether being a commissioner of insurance or a interim CMO of a PBM or the medical director of a health plan, is that a lot of times when these switches happened, it wasn't that the plan was switching, it was that the employer was carving out to a new pharmacy manager, and there was nothing we could do. They made a business decision. So I know from your point of view, it's all just the insurance company, right? And I understand that, but sometimes it's taken away from us.
Well, but wherever the decision is made in the pathway, I mean, we're all in this to try to improve the care of the people we're taking care of. And I think it's just really important to understand that if you don't know how to use the devices you're using, that it's problematic.
Yep.
It's also, by the way, and again, I'm sure it's not with the plans you guys have worked with, but it's also extremely frustrating when we get a request to say that this LAMA/LABA isn't available, and one of the choices is Combivent, which is a short-acting LAMA/LABA, SAMA/SABA, but not part of maintenance therapy. It doesn't provide many of the other things. So when you get the request form from wherever it's coming and says you can switch to, and this is one of your options, it suggests a lack of understanding, which is problematic.
Yeah. But also what Byron said, I mean, I think it is our problem when we're paying for a drug and patients aren't taking it correctly. So back to the point of training, and if there is a switch, what can we do? And we have disease management, we have clinical pharmacists, we now have technology that can do maybe a Skype video to help patients to train them appropriately. So I would actually, put the onus on us collectively to say, what are some of the ways that we can overcome some of these training
Yeah,
barriers?
and having the inhaler videos available, whether in the app or a different portion, perhaps potentially getting pharmacists who work in CVS and Walgreens to be able to show the person how to use the different devices. But we have to get away from this issue of somebody's changed their drug and they're not using it. Before we leave this issue, I do have a question for Frank, though. And that is that there's some data suggesting, particularly in people who have more severe disease, that they don't have the inspiratory force to get some of these drugs in. Should that play a role in the decisions that we're making?
So
Complicated
I
issue.
would broaden that a little bit to say that different patients seem to sync with different devices. Some of it is cognitive related, dexterity related, severe arthritis. Some of it is inspiratory flow rate. To answer your specific question, there has been some discussion that particularly the more severe patients, small, petite women in particular, can have trouble activating some of the dry powder inhalers. I can tell you that there's truth in that. It has to be recognized, but as in many things, it may have gone too far and needs to be pulled back. I think some of the patients with more severe disease, especially with variable rates and especially if they're not educated on how to use the devices, can get below the inspiratory thresholds in that cases. I mean, and in some cases, nebulized therapy are indicated in patients that can't coordinate with devices in general or who are particularly arthritic. In general, dry powder inhaler devices actually are preferred by patients and they're the easiest to use. So, you know, you have to balance this contradiction. And so the answer to that is if the medicine doesn't get down in your lungs because you don't know how to use the device, it's not going to do well. And different patients sync with different devices. So I'm a big fan of a redundant formulary. And I always make that argument to at least have a couple of choices, at least on the...
Let me just follow up on that because I think it's really important. It's our job as providers, at whatever level we're providing, to provide something that works best for our patients. So while we have a limited number of types of drugs that are available, there are a number of different ways they can be delivered. And if you find someone who's struggling, you can often find a different approach that can work with a different variation of the drug using a different device. And over the last year or two, there have been a couple of nebulized llamas that have finally gotten into the formularies. So there are options available. Clearly, a single device, you know, once a day would be ideal. It may not be ideal for every one of the patients we're dealing with.